From the Zoomerplex in historic Liberty Village, theZoomer, hosted by Marissa Lennox.
Welcome to theZoomer. I'm Marissa Lennox. In a nation that prides itself on universal health care, it is shocking to think that millions are struggling to find a family doctor. In Ontario, about 2.5 million people are without one, and across Canada, that number is over 6 million. So, to address this huge issue, the provincial government has appointed former Liberal Health Minister Dr. Jane Philpott to connect every Ontarian to a primary care provider within the next 5 years. On top of that, she is also the Dean of the Faculty of Health Sciences at Queen's University. She's written a book as well called Health for All, A Doctor's Prescription for a Healthier Canada, and she joins me now. Dr. Philpott, it's good to speak with you.
Thanks so much for having me.
Well, there's been no shortage of politicians that have thrown money at the healthcare system, believing or maybe hoping that it would solve the primary care crisis. You have a very big mandate and a tight timeline. So can you tell me what the strategy is?
So the strategy is, first of all, some of this has already been done, but we need to map out exactly where that gap is. So if there are 2.5 million people in Ontario, we have a rough idea where they all are now, but we're going to get down to the fine details and determine the areas of greatest need, because we will not be able to fill the gaps immediately overnight, even though all of those 2 million people and their families are really quite desperate right now. We will have a strategy that will both add capacity to the primary care providers that are already doing a great job and trying their hardest, but with potentially some extra resources, some extra supports in the way of nurses or nurse practitioners might be able to care for more patients and be more available. But it will also require the addition of new primary care teams in those areas of greatest need, in those cities where there are tens of thousands of people who don't have access to primary care. So we're going to map out all of that strategy, and I look forward to unveiling the details in the early months of my time in the new role.
And I know it's early, but how do you, perhaps do you anticipate, or how do you intend to address pushback from doctors that may resist being collectivized? Because 9 out of 10 work as a small business right now. So, it's one thing to say they will form teams, it's another to actually execute on that.
That's a great question. I mean, the good news is the family doctors themselves are the people who are most seized with the importance and the urgency of this problem. They are working at full tilt. They're exhausted. The pandemic hit them very hard, and they recognize that something needs to change. And so I know that the amazing family doctors across the province are enthusiastic, and I've heard from them immediately, the family medicine organizations, to say, let's figure out how we can do this together. Nobody will need to change their work arrangements. Those for whom things are going well and they love the practice that they're in and their patients have access, then that's wonderful. But for those who are saying, I need more help, then it will be my job and my team's job to say, what is it that you need that would make it more possible for you to be able to either care for more patients, be open longer hours, reduce stress, reduce administrative burden, stay in the system, keep serving people so that you don't have to retire early out of exhaustion.
Now, you mentioned every Ontarian will have access to primary care. Does that mean every Ontarian will have access to a family doctor?
Well, we know that it's really important that people do have a long-term relationship with a provider, and usually that's a family doctor, but we have heard from Canadians, and there are lots of researchers that have looked at this, and many Canadians are very happy if their longitudinal continuous relationship is with a primary care nurse practitioner who works in a team that includes family doctors and others. So it's important that you have that relationship with that one person who knows you and your family and your medical history and sticks with you over time, and you stick with them. But that person cannot possibly be available every single day of the week and every single week of the year. So it's important that those family docs and NPs are part of a team, so that on the specific day that you get sick, if your family doctor is already fully booked, you can see someone else on the team. It might be another family doctor, it might be a nurse, maybe it's actually a social worker that you really need to see, or a dietitian. And the ability to be able to work in teams allows us to be more efficient, and addresses the reality that we actually don't have enough family doctors right now to make sure that every person sees at every visit their family doctor.
What do you think the role is for profit health providers like Maple or Medcan in this situation?
It's a great question. There has always been some private partners that are part of our healthcare system. About 30% of healthcare delivery in Canada is private care delivery, and it's always great to have a range of partners there. The importance, though, is that nobody is refused access to care because of their inability to pay. So that doesn't mean that there aren't private providers in the system. There are all kinds of amazing private providers everywhere, but it's the fact that that for that essential care, that there will be public health insurance that will ensure that you'll get that care paid for.
But you do believe there is a role for profit family doctors, for example, or doctors to provide family care?
Well, in fact, many, if not, in the rest of the country, most of the family doctors work as private practitioners. We talk about doctors being in private practice, and that's always been the way that doctors are working in those systems. There are a few doctors that work in systems where they're on salaries that are a little bit differently arranged. But it's not necessarily about the private delivery of care. There's lots of that. There will always be lots of that. What we need to make sure is that people get access to care in the order that is needed because they have the medical need the most, and that they will always have publicly funded health insurance to support that delivery of care.
All right, my last question is this. What do you say to Ontarians that are anxious or frustrated about the current state of our healthcare system right now?
I think my main message would be that there is hope. I am thrilled that this position has been made available. There is a solution. I think what made us despair so much in the recent months and years, as we've seen the massive gap in access, is people thought that the system was broken beyond repair. It is not beyond repair. Thanks for sharing about the book. I tried to explain that hope in the book, and I'm really delighted that the province has said, yes, let's do this. Let's be the province where we know that every single person will have access to a family doctor in a primary care team.
All right, Dr. Philpott, we'll have to leave it there. I really appreciate you taking the time, and all the best with your mandate.
Thanks so much.
When we come back, our medical panel will join us on the other side. Don't go away. And now joining us at the Zoomer Roundtable, Dr. Iris Gorfinkel, Dr. Michelle Acorn, Dr. Sarah Newbery, Dr. Bill Cherniak, and Justin Bates. Welcome, everyone. Look, this is a topic that matters so much to our viewers. So many people out there are struggling to find a family doctor, and it's very personal. But let's kick off sort of with a big picture. Is this a mandate that is achievable in 5 years? What are your thoughts, Dr. Gorfinkel?
In the next 6 years, Canada will lack 50,000 family doctors. That's how many we have now altogether. So do we have space to share the pie? I think we do, and lots of it.
So you support her plan. Do you believe it's achievable in 5 years?
That's a big, tall order. I think 5 years is asking a lot. And unless we reimagine the electronic health record, I don't think it's possible.
Dr. Newbery, as a family doctor working in a remote community, how does your firsthand experience stack up against Dr. Philpott's plan?
Yeah, thank you so much for the opportunity to join you today. I'm actually here in Vancouver at the National Family Physicians Conference, and I live and work in the community of Marathon, which is about halfway between Thunder Bay and Sault Ste. Marie at 5,000 people. It's the largest dot on that 700-kilometer stretch of road. One of the things that I'll say uniquely about rural Ontario is that where family physicians are in practice in rural communities, they are often not only doing primary care office-based practice, but they are also working in the emergency department, working in the local hospital. And so the loss of a family physician to a rural community actually impacts the entire local small healthcare system. And so ensuring that we have family physicians in every corner of the province matters hugely to health services delivery beyond primary care.
And Dr. Newbery, have you heard of family doctors being flown to Northern Ontario in order to meet that demand?
Absolutely, it happens actually every day. It happens primarily to cover emergency department shifts that remain open, and those are often covered by family physicians who work and have skills in the emergency department. But there are family physicians who are flown into Northern Ontario regularly to be able to provide care. And we know that in many of the communities in Northern Ontario, there are critical family physician shortages. We know, for example, that the community of Rainy River will be without family physicians at all at the end of the month. We know that Thessalon, between Sault Ste. Marie and Sudbury, has been without family physicians for many, many months. And so family doctors are flown into those communities in order to support the provision of care.
Yeah. You know, Dr. Acorn, for nurse practitioners, how ready do they feel to step in for family doctors? Because, of course, that is a big part of Dr. Philpott's strategy.
Absolutely. Thanks for the opportunity to be here. Nurse practitioners are ready, willing, able, competent, and safe to step in. Did you know there's more than 5,300 nurse practitioners across Ontario in primary care, long-term care, corrections, hospitals as well? There's over 10,000 in Canada. They're increasing by 10% annually for the last 10 years. So they have the knowledge, skill, and judgment to be able to be your primary care provider as well as specialty care providers. And you're absolutely right. Nurse practitioners are being flown into northern remote areas as well. There are models of care already, such as nurse practitioner-led clinics, where your primary care provider is a nurse practitioner and leveraging the interprofessional team.
I'm curious, what would you say to someone who may find it a little unsettling that their primary care provider is a nurse practitioner? Because after all, we've been told our whole lives, you need a family doctor.
Yes, well, I've devoted my my whole career to being a nurse. I guess I would say, did you know, on average, registered nurses have at least 10 years of experience before they become a nurse practitioner as well. We have overlapping scope of practice. The evidence is astounding. We're one of the most highly researched professionals out there for safe, effective, efficient, collaborative care as well. And we work across systems. And really, the other piece is very public trusted. We marry nursing and medicine, and we work in teams. And we very much respect our physician colleagues, our pharmacist colleagues, and the full interprofessional team, no matter what model of care we may look like.
Justin, pharmacists too will be part of these teams. How do they feel about this plan?
Well, in a similar fashion, it's about access. It's about complementary care that's both collaborative and competent. Pharmacists are stepping up across the country, providing services that are primary care, public health, and medication management. And we do so as part of that overall team. And we're there to serve the patients and make this as easy as possible and to create capacity in the healthcare system, because not only are there gaps in family physicians, but we don't need people showing up at emergency departments with an already burdened system. So there are ways to alleviate that burden within the healthcare system and do that with community-based care through healthcare hubs and healthcare teams, and that's through pharmacies and other healthcare providers.
Dr. Cherniak, I'll get you to jump in here. Obviously, Dr. Philpott's plan is aimed at Ontario. Do you think this is something that could be scaled up across Canada?
Yeah, absolutely. And I was just thinking and reflecting, it's interesting. Dr. Newbery mentioned doctors getting flown up into Northern Ontario. I actually was one of those doctors that went to Thessalon, in fact, to cover the emergency department last Christmas to help keep it open. And I'm in Calgary, actually at the moment, heading to a rural emergency department in rural Alberta over the weekend. And I think that, Dr. Philpott mentioned that we can learn from international settings on how to build primary care domestically within Canada. I think there are also models within provinces in the country that are great to look at. So, for example, BC produced a longitudinal family practice model, and it's interesting because they didn't, say that we're going to penalize physicians for doing certain things, but rather we're going to reward family doctors for doing that administrative work that's required to manage your practice. And we're going to open up flexibilities to also allow physicians to collaborate in these interdisciplinary teams and even physician teams, but in both in-person and virtual ecosystems, and be able to, have novel, innovative models that leverage technology to improve access to care. So I think there's a lot that's possible if we sort of get creative and start to learn from other areas.
Dr. Cherniak, what do you mean by reward?
Well, so essentially the LFP model in BC, there's so much uncompensated work. And my training's in both family and emergency medicine, but there's so much uncompensated work that family doctors have to do to manage their practice with administration, reviewing labs, imaging, just basic things that are required to run a practice day to day and keep people healthy. And so often that work you just sort of do in your pajama time, we call it. But British Columbia has recognized that actually takes time, and you need to, help physicians to manage that load. And so they've included those in the new billing model for family doctors in the province.
All right, let's pause here. We're going to take a quick break, and we'll be right back with more of the Zoomer.
Well, it's a beautiful day to be outside the Zoomerplex asking local residents about their experience with Ontario's healthcare system. Do you have a family doctor?
No.
No, I don't.
No.
No, I don't.
It's impossible to get one in Ontario. I actually had surgery a few weeks ago, and I actually had to go back to Alberta to get it done.
It was really hard to find somebody. I go back to my country every now and then, right? So, I prefer the medical system there rather than here.
Technically, it's not a doctor, it's a nurse practitioner. But, they're overseen by a doctor, right? But, it's in a clinic. And if that doctor retired or moved on or whatever, they'd probably supply me with a replacement.
Summary statement on Canada's healthcare system in general?
Oh, in general, it's overloaded, it's horrible, and Canadians need to be prioritized in it because province to province, it's impossible.
I'm a long COVID sufferer, so I have to do appointments pretty regularly, and it is about a month out.
I think it has a lot of room for improvement. We need to keep it public, I believe, but there should be room for private options if that will help, open up some space in the system.
I think you should open up privately a bit because public system's getting overrun, it looks like. So, especially with the, record immigration levels. So you got probably need to open up the public side a little bit more.
Do you have a plan on what to do if your family doctor retires? How you'd switch?
I've never even thought about that, to be honest. So no plan. Just gonna wing it.
Well, as for now, that's the word on the street. Marissa, back to you in Zoomer Hall.
Thanks, Max. Nearly 1 in 6 family doctors in Canada are 65 and older and nearing retirement. And according to the Ontario College of Family Physicians, approximately 1 in 4 Ontarians, that's 4.4 million, will be without a family doctor by 2026. To put that into some context, there are only 16 million people in Ontario. Dr. Gorfinkel, when a family doctor retires, what usually happens to those patients? Are they referred elsewhere, or is it sort of like a good luck situation?
It's a good luck situation, depending on who's available, who the family doctor can find. Is there a locum? Is there somebody willing to take the practice? Beg, plead, fall on the face. This is what we've come to. Even in my own practice, if I try to take one day off, it's really challenging. If I don't have somebody to back me up, that means all of those patients are going to be left without care during that time. Mm-hmm. And so what is a patient to do? What does this mean to the individual? And don't forget, we are the gateway to every other service.
Dr. Newbery, what happens to patients in rural Ontario where family doctors are even harder to come by? Is there any way for a patient to know whether or not there is a doctor available in that neighborhood, let alone a doctor worth their salt?
Yeah, so in rural communities, often navigation of the system can be much easier. There's often only one clinic, there's often only one hospital, one pharmacy. I think the challenge becomes when a physician retires or a healthcare provider leaves that community context. It's actually very difficult to find services locally. There are not the layers of service availability in rural communities that there can be in urban settings. So for example, if someone lost their family physician in an urban setting, they might have some choices around walk-in clinics or other service providers that they could access care through. And those layers of care just don't exist in most rural communities. So that creates a huge challenge. There are certainly numerous stories of family physicians who have been ready to retire for sometimes several years and who have chosen not to retire because they know that that would leave their patients without access to care. And we know that there are patients who have remained connected to family physicians at a distance. So if they've moved to a rural community and can't access care, and they have been fortunate enough to have a family physician in another community, they've maintained that tie, even though the challenges of access can be quite significant as well.
We had a viewer write in that they drive 5 hours to see their family doctor because there are no family doctors available in the neighborhood to take them on. Dr. Cherniak, is the same true where you are?
I was just thinking about my last shift in the ER, and I do tallies these days about the proportion of patients who have family doctors and don't. And it's interesting because I'd say probably 1 in 2, if not 75% of the patients I see don't have family doctors anymore. Or I ask, what brought you into the ER today for an issue that may have been something that's chronic? And they said, well, the next appointment available is a month from now. And so it speaks to the challenges we're experiencing. But I think that, it's difficult for patients to figure out where to find a doctor in the first place, like you heard as well. And so how do we get that information to patients, and how do we take doctors who maybe want to see patients but maybe can't fly into that rural community and get them access through, novel, innovative models? And there are doctors that are willing to do that can't fly but maybe will see patients. So how do you connect the dots in those places? But I sort of
Part of the problem is that we are not making the most of the family physicians we have. So family doctors...
Because of the administrative burden.
Oh, it's the admin. Why am I giving a vaccine when you need a high school degree to give a shot?
Right.
Why am I doing colorectal cancer screenings, asking the same 5 inane questions repeatedly when a machine could deliver that better than I could? So we in our own office did research demonstrating that with a digital tool, I'm reaching out to my entire practice. And what happens is that my engagement went from here to here in terms of cancer screenings. So we can make much better use of a family doctor's mind and time by making more of the electronic health record and reimagining it. Instead of looking at it as a repository that we simply put information into, it is a tool that can reach directly out to patients.
Dr. Gorfinkel, I agree with you on the electronic medical record, but where's the incentive to actually get that done? You need a provincial government willing to execute on it, because for years we've been talking about this.
You are so right. And you know what? Here's the brick, here's the head. This is what's going on. And it's so darn frustrating because we have the technology. We have, sitting at this panel, every single one of us represents the same vision. A family doctor, a chicken in every pot. Everybody gets a family doctor and access to care.
And access to pharmacists. I thought it was phenomenal what Ontario did expanding the role of pharmacists. I have no issues going into a pharmacy and getting a prescription or receiving a vaccine.
Yeah, no, and great points have been raised around we need to have a patient-centered approach. And I think the challenge we have is it takes the political will, the financial commitments and investments across the system in order to bring people together beyond election cycles. And we have a system that's set up that's very siloed in the budgets, whether it's a drug budget, whether it's the hospital OHIP budget, primary care, public health. And it sets us up almost against it's a huge barrier to being able to bring this collaborative care model that exists in different models of care. And you've talked about some of the pharmacist and nurse practitioner-led clinics. We see that across the country. Ontario lags behind most jurisdictions across the country when it comes to scope of practice. There's tons of data out there to show how effective pharmacists are in particular, but others as well, in providing these types of primary care hubs. And in Ontario, we've had, since January of 2023, over 1.5 million assessments done for the 19 minor ailments conditions. And that's a very short list compared to other jurisdictions where it goes well above 32, and in some cases, completely autonomous prescribing. So we need to get away from a fear-based approach and talking about, what is competency and safe and effective, and really work together with all of our healthcare providers to put that patient at the center of what we do and not be fighting over slices of pie within budgets of provincial governments.
All right, quick break. We're going to be right back on the other side. Don't go away. We're back. Let's pick up where we left off just before the break. Dr. Gorfinkel, here in Ontario, we already have a mix of public funding and private delivery. And we saw the Premier pass a bill to allow more private clinics to deliver OHIP-funded surgeries. And I'm not interested in reopening that debate, but I am curious, we're a bit down the road now, because there's a lot of outcry about, oh, this is going to lead to more privatization, the P word we dare not mention. Has it been successful in terms of reducing wait times?
Privatization increases wait times. Period. Full stop.
What the Premier did in terms of allowing private clinics, because what difference does it make who performs the surgery?
Right. So if a body is taken from the public system, that leaves one body less in the public system. And the rate limiting step here is healthcare workers. So if the healthcare workers are not manning the public system and in the private system, wait times go up. Please check my work on this.
Have they gone up?
Yes, they go up in tandem as private services expand. And it's interesting because Ontario is landing in a curious space. On the one hand, private services are being vastly expanded. And on the other hand, Dr. Jane Philpott is tasked with changing and providing health care to all Ontarians within 5 years. And I ask, how are both possible when one is competing with the other when it comes to manpower?
Well, Dr. Newbery, she didn't seem to have a problem with it.
Yeah, I think there is a really important conversation to have right now about access to care. And I think when people feel like they can't access the publicly funded system, they will turn to privately funded sources to be able to have some kind of access. People need healthcare. What we know, though, and I think Dr. Philpott referenced some of the really terrific research that's happening in Ontario. There is a study called the Our Care Study that asked Ontarians, it's sort of the largest citizen survey in Ontario and in Canada, about what citizens want from their healthcare system. And that was very clear. They want access to a primary care provider, either a family physician or a nurse practitioner, in a team-based environment that is publicly funded. And I think if we could guarantee that access, people would choose the publicly funded system. We have a lot of work to do to improve the way in which people can access care, and to Bill's point, to Dr. Cherniak's point, to be able to access that not a month from now, but in a really timely way, at a time that people need the care they need.
You can't blame someone if they have the resources to want to pay out of pocket for healthcare in order to access it sooner, Dr. Acorn.
Absolutely. So a couple of great points, and I'll speak obviously to nurse practitioners right now, but we have nurse practitioners that are unemployed, underemployed, and underutilized. And we spoke about the Canada Health Act as well. And it does include physicians in hospital services. It has not modernized. There's been some interpretation letters that talk about shifting into the community, for example, but we're on a critical juncture right now. Nurse practitioners are setting up private clinics right now because our citizens do not have access to primary care. This is not about greed. This is about need right now. And the other issue is there's not dedicated, flexible, easily accessible funding right now for whether nurse practitioners want to join your clinic, for example, work in emergency departments, wherever that may be across the system right now. It's critical. And many are doing free for service because people do not have the ability to pay. We also have other people that have access to their extended health benefits and insurance opportunities right now, and people are so desperate.
Dr. Cherniak, I'll give you the final word on this. You know, we're talking about fee-for-service care. We see a lot of countries with universal health care, France, Germany, Sweden, Switzerland, that have some kind of a hybrid model, and it seems to work for them. Why couldn't it work for us?
Yeah, and it's a great question. And I echo some of the other I maybe was a little bit surprised by Dr. Philpott's response about 30% of healthcare being privately delivered. And you know, I think it's great to consider how we can work with partners across sectors. But my sort of thinking around it is that if patients do not have a publicly funded option that is accessible and available to them, why prevent them from doing something that enables them to access healthcare services? And so I think the key is what the Canadian Medical Association put out in its report not so long ago, which is that governments need to fund healthcare at the same rates and at appropriate rates in order to ensure all patients have access to high quality publicly funded solutions. But in parallel, yeah, I don't agree that you need to prevent patients from being able to access care if a publicly funded service option isn't available. And so I think that's that kind of hybridized model you're tapping into. But the question is, how do if you did have the perfect public healthcare system, then yeah, you wouldn't need the private part of it. So how do you get that blend right is the tough question to be solved here.
All right.
Can I add one point, if you don't mind? In the primary care arena right now, recruitment and retention of the health workforce is vital right now. Our physician colleagues, our pharmacist colleagues, the full interprofessional team needs to be compensated. In primary care, there has not been an increase in over 7 years, and there's no harmonization across the sector. So if we're going to remunerate and get people back into primary care, we need to ensure that it has the respect, recognition, and remuneration that's attached, and it's valued as in primary health promotion, chronic disease management, and it doesn't favor an acute care system.
To your point, France, Germany, Italy, the UK all spend 8% of their healthcare budget on primary care. And where is Canada? 5%. That's a massive difference. So an investment in primary care? Absolutely. Was this foreseeable? 100%. We're graduating 1,500 family doctors a year. And where are they going? They're not going into longitudinal care. They're heading off to do other things.
All right, we'll wrap it there. It's been a great discussion. Up next, we're sharing your stories about the healthcare system. Stick around. You won't want to miss it. Thanks for sticking with us. Now we're turning to you for the next part of our conversation. We love hearing from our audience members, both by email and also in studio. So let's bring George up to the round table. What's your question, George?
Yes, how long can it take to get a new family doctor? And is there anything I can do to speed up the process?
Go ahead, Dr. Gorfinkel.
So the College of Physicians and Surgeons offers a list of family doctors still accepting patients. Failing that, which unfortunately that does fail, it's word of mouth. So I hate to say it, but it's a really helter-skelter kind of system. What should be happening is that the system should have a first available family doctor. Now, sure, it may not be directly in your area, ideally it would, but that's the kind of system we need. Just like you line up at Walmart, right? So it's the first available. That's what we should be doing.
So what advice do you have for George here?
Word of mouth. You're left with a helter-skelter system we have. You could try the college. You could try a walk-in clinic doctor. Because, start looking in the papers for people who are advertising. There are family doctors, and it is being expanded, but you got to work to get it.
All right, thank you, George, for your question. Next, we have Alice. Welcome to the round table. What's your question?
My question is, I'm asking it on behalf of my daughter who is living in Sault Ste. Marie and is one of the 17,000 people who was left without doctors once a clinic closed. She has medical issues and which require specialists who she sees in Toronto. And she's expressed her frustration to me as to not being able to get a family doctor. Who gets priority while on waiting list to get a family doctor?
So first of all, to get from Sault Ste. Marie to Toronto, you have to take a flight.
Mm-hmm. Either that or a drive. Yeah, she takes a flight. Yeah,
it's a long drive.
Yeah.
Dr. Newbery.
There has been a system called Healthcare Connect, which is meant to prioritize patients who have significant health needs for priority access to family physicians or a nurse practitioner, so that people like your daughter who have complex chronic conditions or ongoing healthcare needs can access that care provider in a way that provides the kind of continuity of care that we know improves health outcomes. That's a big part of the reason for having a family physician or a nurse practitioner who knows you well. The Healthcare Connect system has been quite overwhelmed, and in Sault Ste. Marie, we know that people have been waiting for many, many months and sometimes years. There is not currently an easy solution to that in Sault Ste. Marie, but what people like your daughter can do in the interim is ask for copies of their records from the healthcare providers that they see, from the specialists that they see in places like Toronto and in other places, so that they can carry those records with them. It is a poor second best to an integrated online record that all healthcare providers can access, but your daughter may find herself in the situation of needing to access a walk-in clinic or urgent care or the emergency department in Sault Ste. Marie, and being able to have her important records with her in case the providers that she sees can't access those records themselves is an important way for her to try and optimize her care as we continue to work to improve the system and increase the number of family doctors and nurse practitioners who are available to provide care in Sault Ste. Marie.
Doesn't this really summarize healthcare in Canada in 2024? I remember seeing in the news when Kingston Clinic opened up and people were lined up in tents at 3 a.m. to try to get to that, your example of Walmart in a lineup. And it's like the Hunger Games. And I think it's unacceptable that we talk about a universality of a system that we have and the principles behind access, but we're not actually making the investments to avoid those types of scenarios. And it's a real tragedy in my mind.
People who have a family doctor live longer. Longitudinal care makes them live a longer, healthier life. So it's not just a matter of span, it's quality span as well. And when I hear that story, I feel personally ashamed of a system that is failing its population. Can we do better? We can do way, way better. Is the will there to commit to the public system? That's another question.
All right, we'll take a quick break here. Stay tuned because there's more of your questions coming up next. All right, we're back and we're going to pick up with some more of your questions. Next, we have Sandra in our audience. Go ahead, Sandra.
If someone can't access a family doctor in person, should they consider virtual care? And if so, how do you go about it?
Dr. Cherniak.
I'm happy to help on this one. As some folks may know, I actually founded a digital health company called Rocket Doctor at the start of the pandemic, largely informed by my work in the emergency department, seeing patients without family doctors coming in with outpatient primary care issues. We're somewhat unfortunate in the province of Ontario that the government cut funding by 50% to virtual care for patients who do not have family doctors. And so the average physician who may be in downtown Toronto, Ottawa, London, who wants to provide care to patients in rural remote communities or who just doesn't have a family doctor is now entirely disincentivized to do that. And so we've seen a big drop in ability to access services that are publicly funded in Ontario. However, that's the only province in Canada that does that. And so in Western Canada, BC, Alberta, it's a great solution for patients in order to access care and in fact, refer patients frequently to do so. Lots and lots of data and literature from the World Health Organization, from the United States, from our friends in Europe, that virtual care is safe and effective when done properly, where doctors are empowered to order blood work, labs, imaging, book follow-ups, make specialist appointments, and care is coordinated effectively, as we heard, in a longitudinal fashion, which certainly can be done virtually in the right model.
All right, we've come to the end of our conversation, so I'll just go around the table one more time. Dr. Cherniak, what will you leave us with?
Yeah, I would echo that we have a big problem with access to healthcare services in Ontario and across Canada, but we also are building on a foundation of one of the most, I think, successful publicly funded healthcare systems on the planet. And with some of the most well-trained physicians that I believe exist around the world. And so I think we have a really interesting and unique opportunity to leverage that insight, talent, and foundation to work with folks like Jane and the team of folks across the government and otherwise to actually build a system that works for everybody and increase access to care and using all these new modern technologies that are now available to us to decrease administrative work, improve, the flexibility and overall mental health of physicians practicing as well, and improve access to care for folks across the province.
Justin.
Well, I think this conversation really demonstrates the commitment around the table of the different healthcare providers represented to make an impact. There's not a single solution. There are multiple models of care. We need to make sure that the investments are through multiple years of election cycles and really separate out the politics of this, because it's really, in my mind, it's central to everything we're trying to do, which is improve the quality of life and healthcare access for Ontarians and Canadians. And we can't do that unless we are appropriately compensated and we have the appropriate IT infrastructure and reducing the administrative burden. And innovation is a big part of that. We talked about it a little bit today. We need to make sure we unlock the value of all healthcare providers, tapping into their expertise and work together in a collaborative way, using innovation and technology as an enabler.
Dr. Acorn.
Thanks for the opportunity to come today. Nurse practitioners are credible, legitimate, safe providers. If we have the opportunity to leverage them as solutions right now, not just as a stopgap, but into the future, I think we'll have a great opportunity. They're not just clinicians, they're thought leaders and experts, and they can help lead teams together with the interprofessional team. And let's make sure that we're delivering holistic care and at the decision-making tables to inform the data and dialogue and ensure that we're all dedicated and respectful to one another as well. And I thank you all for your service.
Canada graduates 1,500 family doctors a year. In the next 5 years, we need 50,000 more family doctors. So do the math. It's not going to work when you add in the retirements. So unless each and every one of us around this table is holding hands in a cooperative way, it ain't gonna work.
Mm-hmm. Dr. Newbery.
I really want to reiterate that a high-performing primary care health system is the foundation of high-performing health systems everywhere in the world. And we know that when we provide excellent healthcare in a team-based environment that is well coordinated and delivers comprehensive care with continuity of relationship with a primary care provider and team, people live longer, outcomes are better, hospitalization is decreased, costs overall are decreased. And I don't think it's a matter anymore of not knowing what we need to do. We know what we need to do to move forward. We need the political will and the resources to implement those solutions and to implement those solutions in service to every Ontarian, no matter where they live.
Well, I know that the future may be daunting, but I, for one, was left with some hope after this conversation. So a big thank you to all of you for being here. That is it for us this evening. To get in touch, you can send us an email at comments@thezoomer.com. For now, it's time to zoom out.